start with a little trivia. Does anyone know, do we have a vaccination that has been FDA approved in pregnancy? Just shout out. So I would have said no. Okay, no one's answering me, but I would have said no. But actually, there is a vaccination approved for pregnancy, and it is Rogam, believe it or not. It was approved in the late 60s, early 70s. And Rogam, RHD immune globulin, is considered a vaccination. And so it's the one and only vaccination that has been FDA approved in pregnancy. So I decided today that, the management of isoimmunization is usually left up to the MFM doctors, and the majority of what we do is the prevention of RH isoimmunization. So prior to Rogam, the rate of affected fetuses was around 15%. And with one dose of Rogam after birth, it dropped it to 0.5 to 1.8%. Once we introduced the second dose of Rogam at 28 weeks, it dropped further, and most reports say it's less than 0.2%. Next slide. So who should get RHD immune globulin? So there's some things that are very cut and dry. Although we might not have any evidence, we still are sticking by what we've always believed. And the first thing is chorionic villus sampling, amniocentesis, and corticentesis are all, Rogam is recommended after all of them. Now, threatened miscarriage or a miscarriage. So if a woman is bleeding in the first trimester, does she need Rogam? And I have always been trained to give her Rogam, but just know that there is a group of individuals that say that that you have never seen anybody that had been sensitized by a threatened miscarriage, and therefore it's a waste of Rogam to give all of these patients Rogam if they're Rh negative. Now, if you instrument a first trimester pregnancy, meaning do a D&C or you do a surgical surgical D&C, you need to give Rogam. It's only if there is a spontaneous miscarriage that there is any controversy. Now, as far as an ectopic pregnancy goes, if a pregnancy ruptures, your risk of having isoimmunization is greater. But if you have a patient that you are giving methotrexate to who's Rh negative, she also needs Rogam, along with any patient that you're doing surgery on for ectopic pregnancy or a ruptured pregnancy. A molar pregnancy, technically you shouldn't have to give Rogam after a complete molar pregnancy, but that is a pathological diagnosis. And so we recommend giving Rogam after all molar pregnancies. and of course, medical or surgical termination of pregnancy. I'm going to skip over the next two and go to intrauterine fetal demise. About 15% of those are due to maternal fetal hemorrhage, and therefore all fetal demises, regardless if it's the second or third trimester, should get RhoGAM. External cephalic version should also get RhoGAM. And at delivery, if the baby is Rh positive. Now, for abdominal trauma, if a patient is Rh negative, what is recommended is that you do a Kleihar-Becky on these individuals to see how many vials of RhoGAM you need to give them. Now, I cannot talk right now. She's going. I'll call her back. I will tell her. Or if it's an emergency, she can call one of my partners. So abdominal trauma, you basically do a Kleihar-Becky, and you quantify the amount of fetal hemorrhage that is in the maternal bloodstream, and you can give the number of, you can give them more than one vial of RhoGAM to cover the hemorrhage. Now, we've all gotten the antepartum hemorrhaged patient with the placenta previa that comes in and she's bleeding at 22 weeks, at 23 weeks, at 26 weeks, and she's Rh negative. So how should you handle that? The way, ACOG recommends, and the way we handle antepartum hemorrhage is what we'll do is we will repeat the antibody screen about every 3 weeks. So she bleeds at 22 weeks and then again at 23 weeks. Well, if she bleeds at 22 weeks and we give her RhoGAM, if she bleeds again at 23 weeks, we don't repeat anything and we don't give her RhoGAM again. But around 25 to 26 weeks, we would then check an antibody screen. If the antibody screen's positive, then we recheck it again in another 2 to 3 weeks. As long as the antibody screen is positive, we don't give more RhoGAM. But when it gets very low, then we will give the patient another vial of RhoGAM. Next slide. Oh, before I leave that slide, we give RhoGAM, as I said at the beginning of the presentation, at 28 weeks and then again after delivery. Some people will argue that RhoGAM is only good for 12 weeks, and if a patient goes post dates like 41 to 42 weeks, that we should repeat the RhoGAM, and that is not necessary. So you can go to the next slide. So the dose of RHD immunoglobulin, there are actually 3 doses. And I don't know about the rest of your hospitals, but MUSC only carries the 300 micrograms. So you can use the 50 micrograms at less than 12 weeks or 120 micrograms at less than 12 weeks. But the 30 micrograms, you can use it after 12 weeks. Now, the 50 micrograms will cover 5 mLs of whole blood, which is 2.5 mLs of red blood cells. The same thing with the 12 mLs, the 120, it covers 12 mLs of blood, 6 cc's of red blood cells. Next, and the argument I told you about the first trimester, the total blood volume in the first trimester is 3 cc's. So the maximum amount of red blood cells they could have is 1.5 cc's. And so that's the argument against using RhoGAM. But again, like I said, we do, or I do give RhoGAM in the first trimester. Next slide. So I don't know how many people are around to, or whether or not your blood bank still tells you that you have a weekly Rh positive patient. In some blood banks, they'll call this DU positive to let you know that this is a D antigen, but it doesn't act like the normal D antigen. And so in the past, if a patient was DU positive or weekly positive, which some labs call, we did not give them RhoGAM. But in the last, in the last 10, 15 years, the American Association of Blood Banks has said that there is more than one genotype for the DU positive patients, and not all genotypes act like it's a positive, and therefore we should call all of these patients Rh negative, and they should receive RhoGAM. And if sometimes we get patients from the outside and they've been told that they're Rh positive, and then they come to us and they're Rh negative, and they get very confused. But it has to do with the DU gene. Next slide. So the other question I get, because some people will come in and they've always done an antibody screen prior to giving the 28-week RhoGAM shot. And then there's some people who've never gotten a RhoGAM antibody screen prior to giving the RhoGAM. And so I'll always get a call from that practice when somebody changes, that does it differently than they do. So most guidelines in the world say you should get an antibody screen prior to the 28-week RhoGAM. Now, at MUSC, we do not get an antibody screen, okay? And I talked with the blood bank a couple of days ago, and one is the cost of the antibody screen. Is the cost of the screen, because, you know, how many times are you really going to find one that's positive? So most of them, 99+%, is going to be negative. And the risk of just giving everybody RhoGAM, even if they are positive, is basically negligible. Now, the other argument is that, well, you know, we could appropriately manage them if we know they were Rh positive, you know, if they had a Rh antibody at 28 weeks. Well, the bottom line, the first pregnancy, it basically usually just has jaundice in the postpartum period, the baby does, and those babies don't run into problems in general with high drops. So the next pregnancy, if they're sensitized, then you'll pick it up on your first prenatal lab, and therefore then you can manage it appropriately. Next slide. So the once in a blue moon, I always get, I forgot the RhoGAM. postpartum, the patient's already home. When should I give it? The most ideal time is 72 hours. And there are reports in the literature up to 2 weeks, and the patient remaining without isoimmunization. But if you haven't given it and you find it out at 2 weeks, 3 weeks postpartum, it's suggested that we give them RhoGAM up to 28 days after delivery, assuming they had a Rh positive infant. Next slide. So with isoimmunization, basically there is a positive antibody screen. And the first thing we need to do is identify the antibody for the antigen for which the antibody is against, because this can be the Rh system, C, D, and E, or it can be of other antigens like Duffy, Kale, etc. So the very first thing I do is I take a history about blood transfusions and what happened in their prior pregnancies. If a patient is a G0 and she's had a blood transfusion, then it had to come from the blood transfusion. And the opposite is true. If a patient is a G5 and she has had 4 affected kids, then that this one is going to be affected too. Or you're pretty much, the baby is at risk. And so people will argue that you don't even have to quantify the antibody when you've had a prior affected baby. You just need to go and work up the patient like the baby has isoimmunization disease. And the last thing is to quantify the antibody screen. So identify, take a history, and then quantify. Okay? Next slide. So the paternal status, I discussed paternity with the patient alone. I just asked her, is there any possibility? I said, this is not a judgmental statement. This is just me asking to ensure that I have the correct information, because if I don't have the correct information, I can just follow you another way. I don't have to say, oh, you're not the father of the baby. I need to go and hunt the true father. I would just never check the father of the baby's status if I knew there was a question of paternity. But if there's no question of paternity, then you can check the father of the baby's antigen status. And most of the time, we can determine if the guy is homozygous for the gene or heterozygous. And for example, if a mother has anti-D antibody, the father of the baby can be homozygous for the big D antigen, or he can be heterozygous. If he's homozygous, then 100% of their children will be Rh positive and will be at risk for isoimmunization. Where if he's heterozygous, then only 50% of their children will be at risk. Next slide. Now, to quantitate the antibody, we all know this, but I'm just doing it for review. The lower the number, 1 to 1, 1 to 2, the lower the number, the least amount of antibody is there. So once you do the second dilution, it goes away, and therefore there's only a small amount. So it goes 1 to 1, 1 to 2, 1 to 4, 1 to 8, 1 to 16, 1 to 32, 1 to 64. And the higher the second number, the more antibody the mother has circulating in her body. Next slide. So if a patient we almost always consult MFM if we have a positive antibody. And if the titer is less than 1 to 8, then you can repeat it monthly until it becomes greater than 1 to 8. But once it becomes greater than 1 to 8 or 1 to 16, then you should refer to MFM. The exception to this is the KALE antibody. I would just suggest that everybody with a KALE antibody just comes straight to MFM, because there's a significant amount of controversy about what cutoff you use and this and that. And I would make the MFM decide what to do with KALE. Next paragraph, next slide. So when a baby is at risk, we use middle cerebral artery Doppler to measure the peak systolic velocity. I think this is just one of the most beautiful images in obstetrics. I actually have the circle, you can see the circle of Willis, and you can see the middle cerebral artery, it's labeled MCA. You can see the posterior cerebral artery, and it's labeled PCA, and then where the anterior cerebral arteries would come off. Now, there is an art to measuring peak systolic velocity. And therefore, if it's not measured correctly, then it is useless. So what I beg of you is, I would beg that you send your patients who require a middle cerebral artery Doppler to MFM and let them follow it up, and them to decide when the baby needs a transfusion. Next slide. And so we practically all use the Maury curve now. I don't know of anybody that still does amniocentesis for isoimmunization. And basically the curve is the average or 1.5 multiples of the median. And once a patient gets above 1.5 multiples of the median, then they should be transfused. Now, we usually ask for a Doppler to be done. We usually do week 1, week 2, week 3, and then we decide how to space them out, whether or not we go to 2 weeks or continue 1 week. Once a baby is transfused, it is not recommended that you do MCA Dopplers. But to be honest, we do calculate when our next transfusion should be, but we also push it out a little bit if our MCA Dopplers are normal. Now, MCA Dopplers are not as reliable after 35 weeks. So sometimes you'll see us just say deliver them because we can't get reliable Doppler information. And that's all I'm going to tell you about. And so you can ask questions if you want.
Thank you so much, Dr. Johnson. Before we go to the question and answer session, just to remind everyone, we'll be back on November 3rd to discuss hemoglobinopathies. And I will also post our website into the chat, and you can feel free to copy and paste that for yourself. And if you would like a copy of today's video, please reach out to me, and I'll turn it over to Barry to facilitate. And also, we do invite you to share your screen during this time. It helps create a sense of community.
Do we have the thing?